Hey guys, so I'm just going to do a quick little video on the internal defibrillator paddles. This is something that the trauma team has said we've had some problems with, and so basically we just want to do a little education on how they work and some things that you can kind of do to troubleshoot if you're having issues with them. This is definitely a pretty physician-led skill, but it's something that we as nurses should at least know how to help troubleshoot if something's going wrong with them or something like that. So first thing, let me just show you this. These are the paddles themselves. So they're kept in the long, skinny Omnicell that's next to the Trauma 3, across from Trauma 3. And basically it looks like this. And inside they look like this. So this is going to be for your clamshell thoracotomy patients that we need to defibrillate, and obviously you can't put pads on them if their chest is open. So we're going to internally defibrillate the heart just straight on the actual heart. So basically these little paddles, each one of them they click in that. Like that, and they're basically little paddles that then go right on the heart and shock it to defibrillate it. So these would be like I said, your clamshell thoracotomies. I won't open the box every time we're gonna crack a chest, or we think we might even, but I'll bring it in the room. We usually don't carry that many of these, like maybe 2-3 sets. So I won't open it every time there's a gunshot wound to the chest. I'll just maybe have it in the vicinity of the trauma room, maybe on the trauma cart or over by the Pyxis or something like that. So then if it's red, if it looks like we're going down that road, I'll go ahead and pop it. But basically that trauma code, gunshot wound to the chest that we know we've already we're clamshelling, I would maybe go ahead and pull these into the room and maybe open the box. But the physicians will tell you, let's get the paddles out. So once they're out of the box, basically they're pretty simple. So on one end is this, on the other end is a cord that looks like that, and that's what's going to plug into the life packs. So on the life pack you'll see it has one end, or it has one type of cord which plugs the pad, the AED pads plug into, but you can see there's another cord that's actually zip tied on here. So what we have to do is actually switch the cords, and then that'll allow us to plug that type of connector into this connector. And then once we do that, now it's all set up, we can go ahead and defibrillate like normal. And then that's pretty much the gist of it. So troubleshooting it. These are, I think, the most important things. I feel like there's 3 main problems that we run into with these. And I think if you're having issues, it's very rarely a equipment issue. I think most of the time it is we're doing something wrong. It's something wrong with the process. So recently, a couple months ago, we had a patient that came in, gunshot wound to the chest, clamshell thoracotomy, tried to do the internal defibrillator paddles. All right, shock them. Nothing happened. Okay, let's try it again. Tried it again. Shock them. Nothing happened. Okay, let's get another set of paddles. We brought in a second set of paddles. Tried those. Nothing happened. Okay, we brought in a second AED at that point. 2 AEDs, 2 different paddles. None of it worked. The patient didn't change anything really with the patient, but we realized, okay, we debriefed. We said there's some lapses here in education on the nursing end and on the physician end. So your paddles are not working, or you think they're not working. First thing that you're going to do is make sure they are plugged in. So I said this first part over here about switching this. This is something that I feel like in that patient, as we look back on it, I don't know that we ever did this. So when you walk up to the AED and it's in its default, it's normally going to have the pad, electrode, the pad plug-in connected to it, and it's going to have that other one just zip tied. Well, I think in this instance with that patient, we didn't realize that this is a separate cord. And so we had just plugged these pads and paddles into here. All right, let her rip. And then when they went to actually shock, well, of course it didn't shock because that wasn't actually plugged into anything. So first step of troubleshooting is make sure that you've actually switched out these plugs. And the first way that you'll be able to tell is when you turn on the AED, the default defibrillation joules is 200, okay? So when you're just like connected to the pads, like the regular pads, it defaults to 200. If you're plugged in to the internal paddles, which is, so if you switch this, it changes the default to, hold on, plug it in, to 10. So basically when you plug those in, you'll know if it's like having you, hey, do you want to charge to 200, then you know there's something wrong. But if it's like defaultly, okay, having you charge to 10, then you know that at least it's plugged in correctly. So that's the first thing. Make sure the paddles are plugged in. Second thing, and this is, I think, also what we were running into in that situation, was shock on the paddles. We don't shock from the AED. I know it's counterintuitive to how we normally defibrillate every other time. When you defibrillate with these internal paddles, the shock gets delivered from the paddles, not the AED. So, for instance, we charge on the AED, and then when the physicians are ready to shock, there is a button on the paddle itself that delivers the shock. So, in that situation, what we think was going on was the physician was holding these. Okay, here we go, getting ready to shock. And then when they went to shock, they were looking at the nurse. All right, shock. And the nurse was then pushing this shock button, which actually cancels the charge. And then the doctor was thinking, oh, well, okay, I guess maybe I push this. And then they push it, but it's not charged. So the shock has to get delivered from the button on the paddles themselves. So if you sometimes have some of these new, like, trauma residents, and they're there and they don't know that they're supposed to deliver this, they'll say, all right, let's shock. And then they look at you like every other time we defibrillate. No, they're the ones who have to deliver the shock on here. They also have to hold it for a second. You can see, like when I did that, it wasn't like if you just click it, you need to like kind of push it and hold it for just a second for it to actually deliver a shock. All right, so you've made sure your cords are plugged in. You've made sure you shock the paddles. I think the third thing that we just need to improve on, and I think this would help solve a lot of these problems, is we need to have like a better line of sight and better communication between the nurse who's at the AED and the physician who has the paddles. So normally, this is how it is you've got your nurse in the corner with the AED. Then a little ways, you've got med students, a whole pile of med students right there. And then the physician holding the paddles is by the patient. So you've literally got like this almost 7-8 foot space between the two with a bunch of people in the middle. And what ends up happening is I go and I say, hey, like, are we ready to shock? And the physician, they can't hear me, and they're saying, hey, are we shocking, or let's shock? And they don't know that I've already charged, and maybe I'm looking at them like, have you delivered the shock? Is something wrong? And basically there's a lot of questions that happen back and forth, and if there's not a clear line of communication between those two people, that's when I think it's harder to troubleshoot. So what I would just say is, when you're doing these, try to think about clearing that space where your AED is and the paddles. Because basically that is going to allow the communication between the two where you can troubleshoot things effectively. So that's basically it, the core tenets of these. Make sure they're plugged in, make sure that they're actually shocking on that, and make sure there's good communication between the two of you. And that's pretty much it. And like I said, it's a very physician-led thing. We won't really be ever the ones making the call or delivering the shock itself on there, obviously. We're just there to kind of help troubleshoot and support. So if you have any questions, send me an email or Helen an email or somebody like that. But all right, thanks.